Right. Good afternoon, everyone, and welcome to this parallel session. I hope that everybody can hear me this time around and that our technology keeps track. So I want to jump in right ahead because I know that we're a little bit pressed for time. We're not going to have a roving mic, just as a quick reminder. If you have any questions, please post it on Zoom, or we also have the menti.com. And then the code to use for this session is 8466687. And then we can just use, we'll facilitate those questions. My name is Regine Leroux. I'm the Managing Director of Reputation Matters. And it's our vision to be Africa's go-to reputation specialists. And this specific topic is so incredibly important from a communications point of view. We've all been through COVID, what worked, what didn't work. So I'm not sure why I'm hearing an echo here. So I'm going to jump right into it, and then I'm going to also hand over to Victor to introduce the next person as we go through each of the topics. Dr. Owens Kaluwa is joining us from the World Health Organization. I know that he's got quite a short time frame to be with us, so he's going to do his presentation. If there are any specific questions for him, then please send that through and we'll make sure that it gets through to him. So Dr. Kaluwa, as I mentioned, is from the World Health Organization, and their three broad focus areas is to ensure universal health coverage, address public health in emergencies, and to promote good health and well-being, which I think now more than ever is the focus for everyone. So without any further ado, Dr. Kaluwa, over to you. Okay, no one can hear us. Can you hear us now? Dr. Beneke, can you hear us? No, doesn't look like it. No, still not. No, we've got this. We've got the microphone.
Can you hear us now, Doctor?
Victor, I could hear you now.
Okay, can you hear me now? Dr. Bianeke?
No. See, if I put my computer's one on, then they can hear us. Right. So Dr. Beneke, you can hear me now?
Yes, I can, but there's an echo.
Yeah.
Maybe try.
Okay, can you guys hear me now, Dr. Beneke? No. Not even from here.
Technology. I don't understand.
No.
Victor, is Regine going to present from the stage? Oh, okay.
I think I know what it is. It's the feed on the audio, on the audio there. Just allow for, if you click on the more button. Okay, I'll come through now.
So I could actually sing. Okay. We are trying this out, but I don't see Dr. Beneke looking, so it doesn't look like we've got the sound back. Can you hear us or not yet? No, still not. Nothing. Renee's putting-
Loud and clear, thank you.
Can,
Thank
I
you.
can hear you now.
Okay, and Dr. Beneke, can you hear me now?
Regine, only from the background, not from that mic, but from the other mics.
Oh, thank you. My laptop mic is on mute. My computer, but now that echoes horrendously.
Okay.
Now I'm on mute. Okay, but you're not seeing my screen, eh? I'm not connected. I just have this for my personal use.
But you know what else you do? Where is the sound? Mute from here as well. Yeah, this one.
Sorry, just, yeah? Okay.
Mute everything.
Everything on my side is muted now. Okay, this is the mic. Testing 1, 2, 3. No.
Thank you, Regine, that sounds good. Yeah,
Oh, you could hear that?
I could hear that. Yeah.
Oh, happy days. Okay, cool. Right, let's get started and very quickly again. So thank you everyone for your patience and welcome to this parallel session. My name is Regine Leroux. I'm the Managing Director of Reputation Matters. My co-facilitator and moderator this afternoon is Victor Sibeko, who will introduce himself in a bit. I think that this topic is incredibly important. We've all been faced with so many issues, specifically from a communications point of view. How do we communicate? How should we have been communicated? So I'm incredibly humbled to be introducing our very first guest speaker, Dr. Owens Kaluwa, from the World Health Organization. Unfortunately, he won't be able to join us for too long, but if there are specific questions, so speaking about questions, if you do have any, please pop them into the chat on Zoom, or we do have the menti.com, and the code to use is 846667. And we're not going to have a roaming mic for our guests and delegates here, so please just pop your questions into the various chat forums, and then we'll facilitate them as we go along. So Dr. Kaluwa from the World Health Organization, the 3 key focus areas for them is to ensure universal health coverage, address public health in emergencies, and also to promote good health and well-being. So I think it's an incredibly important topic to have. So Dr. Kaluwa, I'm handing over to you, and thank you so much for your time today. Okay, maybe Dr. Kaluwa might not be here. I don't see him anymore, but I think...
Okay. While we're trying to find Dr. Kaluwa, ladies and gentlemen, not to waste his time, my name is Victor Sibeko. I'm the Chief Executive Officer of the Public Relations Institute of Southern Africa, PRISA. Welcome to this afternoon session, a very important session. Perhaps we should call upon Mr. Popo Maja, a General Manager responsible for communication and stakeholder management at the South African National Department of Health. Together with Mr. Popo Maja, we have Claudia Shilomani, who is seated with us here right on stage, attending in person, the Chief Executive Officer for Center for Communication Impact, based in Johannesburg, Republic of South Africa. So, Mr. Maja, if you're with us, please, can you then share with us your paper?
I didn't see Popo because I think of the timelines. He was waiting to join a little bit earlier, but I think he's not on the call. But it's okay, he has delegated me to represent him. My name is Claudia Shilomani, and as mentioned, I'm the Chief Executive Officer for Center for Communication Impact. We do strategic communications focusing on HIV prevention, programs for adolescent girls and young women. We also do gender-based violence prevention. My talk today is on COVID-19 and how early on we had actually put together as a collective communication machinery that allowed us to actually disseminate real-time information to South Africans, ensuring that they have the right and correct information at all times on COVID-19. I'm not sure if my presentation is being projected. I would like to speak from the presentation, and I don't know if I should be here or standing there. Is it okay if I'm sitting here?
Well, I suppose for the benefit of the other panelists attending
so
online,
they can see me.
they can see you here.
Oh, okay.
Right.
Can we please pull through my presentation? While we're waiting for it, I just want to indicate that I'm here on behalf of the Risk Communication and Community Engagement Technical Working Group. We are actually one of the 8 pillars of the emergency response coordination mechanism. Generally, when there is an emergency globally or in any country, we follow the international health regulations, which are actually from WHO. And those international health regulations prescribe that there should be 8 pillars that are established. And I'll speak a little bit about that. I don't know how am I punching it to make sure we move to the next level. The next slide. No, I didn't get a flicker on it. Oh, you'll give me one. Oh, that's perfect. So I'll talk a little bit about the subsequent slides, which are not many. So my co-presenter, who unfortunately had to drop because of timing, okay, I'll go back. Popo Maja, he's the head of communications and stakeholder engagement at the National Department of Health. He's actually the chair of the Risk Communication and Community Engagement Technical Working Group, and of course myself. If I go back, you'll see that as I speak, the themes that will emerge include the power of the collective, the power of honesty in communication, as well as the power of inclusivity. So I just wanted to make sure that you see how my presentation is going to actually speak on those 3 issues. As I was mentioning, in any health emergency, whether it's health emergency, any kind of emergency, generally we have these 8 pillars. As you can see, one has to do with coordination at the country level. There's one on surveillance, rapid response, as well as case investigation. Ports of entry, because with coronavirus, even with Ebola, during the time of Ebola, you need to close the borders if you want to minimize infections. National laboratories, that has to do with case detection and all of that. Infection prevention and control, case management, as well as the logistics, because we do need to move large quantities of PPEs and all of that. But my focus today is on pillar 2, which is risk communication and community engagement, which is chaired by Mr. Popo Maja at the national level, with our support, of course. So the guiding principles, without really going that, is that we need to communicate to the public real-time information. In an honest manner. If you look at all this that is being written here, which was extracted directly from the WHO's international health regulations, it talks about being honest, about the unknowns, about what you know, in order to allay the fears among the populace. If there's any change that occurs, whether you get new evidence from research, from whatever it is that is the source of your information, you need to make sure that you communicate, because it's bad to have people thinking of conspiracy theories, thinking of misinformation, spreading rumors. So it's better to always be on your toes when it comes to communications. And of course, the consultative nature. Communities have a lot to give. They've got assets. They also have a lot of misconceptions. There is a lot of discourse that goes on around the epidemic, whether people see themselves as being at risk or they feel like they're not being impacted. So those kinds of things, as you are listening to the communities on the ground, it informs how you now articulate your messages and disseminate such messages. I won't go through this. As you can see on the heading, I said for reference. I kept it because I'm hoping that this will be shared with everybody. But this is just to show the kinds of things that is expected out of a risk communication and community engagement technical working group, which is one of the 8 pillars. So at your own time, you can see in terms of what is expected of us. But the next few slides, I will begin to talk a little bit about what we do, which is actually framed around those principles that I showed earlier. So the Risk Communication and Community Engagement Technical Working Group is supposed to have 5 key competencies. And I'm talking about the competencies in terms of what we have been able to achieve since the beginning of the pandemic. The first core capacity is about risk communication systems. So we need to find a way of a system of communicating the information or the messaging that we need to disseminate to the communities. And we have developed risk communication tools. We have a risk communication plan, which informs all our work. And as much as possible, when we get new information, we update our plan, we update our communication tools, we update our communication platforms. The second core capacity is about partner coordination. So early on, we realized that there's a lot of resources flying around for COVID-19. It was important for us to come together and coordinate our efforts and make sure that there's no duplication and that as much as possible we complement one another. We also made sure that if there are other groups outside of our own group, we reach out and make sure that whatever they're doing informs what we're doing, and what we're doing also informs what they're doing. Like I mentioned, there were 8 pillars, so it's always common for us to invite somebody from case management to come and talk to our group on what's happening on contact tracing, what the issues are, and then we make sure that our messaging takes into account the developments from the other groups. Public communication is where we develop messages, we disseminate those messages and listen to the feedback from communities and reiterate, make sure that we revise our messages according to the feedback that we're getting. And of course, a lot of pre-testing happens to make sure that our messages are relevant and effective. Community engagement, of course, we recognize that having a mass media campaign which is on radio or television doesn't really achieve what we want to achieve. We always make sure that we complement that with community action, making sure that we are at the community level. Even with the lockdown, there were still some community level interventions that were going on. You'll remember there was the door-to-door campaign by community health workers. So some of those community interventions were already going on. Of course, taking into account the IPC principles as well as ensuring safety. And then, of course, the last one is the addressing of misinformation as uncertainties as well as fake news. Let me move quickly because I know that it's going to take forever. So how we're organized is that we've got government departments in the in the RCCE Technical Working Group. Mainly is the National Department of Health. So Popo is the chief director, but he's got several directors who work under him, so they're also part of that. We've got NICD, National Institute of Communicable Diseases. We've got NHLS. We've got donors, USAID, CDC. WHO is a big part of our technical working group, as well as UNICEF, and of course ourselves. We have CHAI, CCI, a combination of local and international NGOs. And in terms of leadership, as I've mentioned, Popo is the chair, and then the convener is one of his director. In terms of accountability, we report to the incidents management team, which is within the Department of Health. It's consisting of technical experts who know what case management is, who knows what diagnostics is. And then we go and report to them in terms of how we're doing, and they give us guidance. And of course, it goes all the way through the Communications Command Center, the NAT joins all the way to the National COVID-19 Command Center, which is chaired by the President of the Republic. And we collaborate with those that I've mentioned below, and you'll see further on as I present on how we collaborate. So early on, which is the reason for this talk, the first case was was announced on the 5th of March in 2020. But even prior to the announcement, once we heard that there is COVID-19 around the world, we started preparing ourselves because we knew that it was just a matter of time, considering the mode of spread of the epidemic. So we waited and prepared ourselves, and we had a risk communication plan in place, waiting. And then on the 5th of March, when the first case was announced, the whole communication machinery was now kicked into gear. And you'll recall that the minister went on TV and announced the first case on the 5th of March. Then we had the Wuhan repatriation. Most of you are aware of that. when the student had to come home from China, they were going to be put at the ranch in Polokwane. There was that whole fear in the community as to what does it mean for us? Why choose Limpopo? Why us? We mounted a communication strategy that involved community radio stations around that area. So about 10 community radio stations were engaged to talk to the populations around the range, just for people to understand that they are not in any way at risk by the students being accommodated in that place. So a lot of the communication happened early on. And when I talk about the power of honesty and the power of the collective, is that at that time, as bad as it was with a lot of unknowns, we actually came together, international NGOs, local NGOs, with the government and said, we're going to do this together. And from that beginning, then the power of the collective became very apparent, and we've been working like that ever since. Popo couldn't be here, and the reason is because on a daily basis, he gets on average 10 media requests. That's on average. It could be 20, it could be 5. But he has to be on the ground responding to these media queries. He works very closely with the minister's public relations officer to make sure that the minister gives daily briefings. There is also, I'm sure you've seen that communication which comes with a map that shows how many cases and in which province, as well as the number of deaths and the number of recoveries and the number of tests that have been done. That's done on a daily basis, and it's coming from the minister's office. So that level of communication is the reason why Popo couldn't be here today, because as I'm speaking right now, he's either addressing one media request or another. And then we can go through all of that. I've already mentioned that we're using radio stations as well as TV to disseminate information, but let me move quite quickly. The power of the collective. I wanted to use this slide to show that we are actually a collective. We're led by the National Department of Health through Popo, but you can see the myriad of partners. And because we do content development, rumor monitoring, social behavior change communication, we do community engagement, we do research, we are leveraging on existing tools, digital tools. And we also benefit a lot from the technical assistance from WHO, CDC, US government CDC, USAID, as well as CHAI. So this just shows you how we are organized. And we work very closely with the provincial communication teams, as you can see at the bottom. So we meet with these provincial teams once a week. We have our own RCCE technical working group on a Wednesday, and on a Thursday we meet with provinces, because whatever we are doing is supposed to be translating at the provincial level. The bottlenecks that they have at the community level, at the provincial level, they communicate at our level, and we try and problem solve together. As I've mentioned, oversight is the Department of Health. Let me move quite quickly. This is just to show you how the provinces actually do their work at the provincial level before they come to the national level. But I'm just gonna skip that so we can move very fast. So we started as a very small group. I mean, around the 5th of March, the 12th of March, we were about 8 people. We used to fit in a very small boardroom at the National Department of Health. But now there's about more than 25 partners. So this is the power of inclusivity. Whereas we started as a collective of about 5, 8 partners, we are now bigger because we didn't close the door. Anybody who is capable of giving input and contributing to what we're doing, we invite them in. Sometimes we reach out to them, sometimes they reach out to us, but we bring them in, and together as a bigger collective, we are able to achieve a little bit more. Let me just go further. The force behind what we're doing. You will recall that at the beginning, it started off as a clinical kind of a response. We had a ministerial advisory committee that was chaired by Professor Slim Karim. And a lot of us who are communicators out there were sitting there thinking, I wish they could give us an opportunity because we know where this is going. My experience from Ebola in Sierra Leone, we only were able to win the war when we took Ebola response to the communities. We empowered the communities to actually take charge of their health outcomes, and we gave them the resources for them to actually even punish those that were seen washing dead bodies, because we knew that they were getting infected through that modality. So we knew that eventually we'll need to move away from the clinical part of it. And this is where the power of honesty comes in. Because our minister has always been very honest. When he doesn't know, he'll go publicly and say, we don't know. What we know is this. I personally, as a public health expert, learned a lot from our minister. Because as a doctor, he's able to articulate medical issues, but he also was very honest in how he communicated. Then he came back in in July, and said, we need a way of supporting communities to move forward behavioral change so that, we can reduce the spread. This was acknowledging that even me as a doctor, I realized that I've reached my limit. My ministerial committee, which is more clinical, now needs the second part, which is the behavioral side of things. And he went on and established the Ministerial Advisory Committee on Social and Behavior Change Communication. And that is where we are right now. We are guided by the Social and Behavior Change Communication Ministerial Advisory Committee, which is chaired by Bishop Pubulan. I'm getting to the end now, sorry. So we have a strategy. I'll leave it to you to look at. This is the framework. Please look at it. The part where we say there are those that are in denial is just to show that, the stage of behavior change, the enabling factors, and the channel that we're using. This is the model. You can read at your own time. This is also for reference, so don't worry about that. And these next slides are also for reference. I want to spend a little bit more time, if you can allow me to talk about this slide, which is the second to the last. Rumors, fake news, misinformation, and perceptions, which includes the concerns from the communities. We are monitoring this on a daily basis. Every day, we have the call center. Frequently asked questions are sent to us. We analyze them. We have a rumor monitoring system, which is now being managed by the National Department of Health. We have digital tools, WhatsApp, all of this, the radio DJs. We actually have a network of DJs who gives us on-the-ground kind of feedback as to what's happening on the ground. So we are monitoring that, and this is how we measure our success. You can also look into that, but we are going to be measuring the impact, which is on the far right, which is the percentage of people wearing masks correctly. So as I look around, I'm gonna see if you have your nose a little bit exposed on your mouth, on your mask, because we need to start wearing masks correctly. And of course, I want to end by saying we have a stories of hope. This is beautiful. We have a 25-year-old nurse who went over and above to actually take care of people. She herself got infected with COVID-19 and she recovered. So these stories of hope from Western Cape, Eastern Cape, and Gauteng actually document the stories from law enforcement officers, from those who worked in malls and shops, from those who were educating our children even when our children were not able to go to the classroom. And these stories of hope actually captures, and it gives hope to South Africans on what was possible during the lockdown when the rest of us were busy, hiding in our homes because we were afraid of COVID-19. That was my last slide. Thank you.
Thank you so much. There we have it, ladies and gentlemen. That was Ms. Shilomani. Very powerful presentation. I like the power of honesty and power of coordination. Now, we are coordinating efforts here to communicate about what happened with the country communication during COVID. I'll hand over to my colleague Regine to introduce the next speaker, and we get a take from that, and then we continue with the program. See all best practices.
Right, I think we're back in business here. Are we? Right. Can the virtual team just give me a head nod if you can hear me, please? Yomi, can you hear me? Okay. Okay, you're on mute, but I can
I can hear you.
Okay, happy days.
I can hear you. I hope you can hear me clearly. because
Perfect.
the audio is poor.
Okay, now
yeah, it's breaking.
Okay,
Yes.
thank you. I'm glad that you can hear me. I can hear you. So just to move on quite swiftly with our program, we are unfortunately a little bit behind schedule. We do apologize for that. Sometimes we just need to be a little bit flexible and agile with these things. I'd like to next introduce Maxim Behar, all the way from Sofia, Bulgaria.